Get started. All right, thank you. Good afternoon, post Cinco de Mayo. It is May 6th for those of you keeping track. I'm actually still waiting for my dinner to be delivered from last night. Never got here. I ordered it online and it didn't happen. So that was fun. So if you hear the doorbell, it might be my dinner. So anyway, just happy to have you here with us during the Telemedicine Echo, focusing on telebehavioral health. And of course, my dogs just ran in. Okay. And so if you hear them, just pardon until I can get them out again. This Echo is sponsored by the HTRC, the Heartland Telehealth Resource Center, and the Missouri Telehealth Network. And we're going to address topics such as technology, operations, clinical, legal, regulatory, evaluation, and we're going to talk about some changes in reimbursement and that type of thing today with Robert Stiles. So he's going to keep us updated, which is a very hard thing to do these days. I'm Janine Gracie, Project Director of the HTRC, and I have the privilege to moderate these sessions. And I just want to give a shout out to everyone who's still working on those front lines. Keep it up. It's working. I hope that we can get through this someday, and be nice to meet face to face and in person someday. I'd like that. So before we get started, I'd like for you to click on your picture or your name, right click, and change your name. So there should be a rename your Echo screen to show your first, your last name, and your state abbreviation. So right click on your picture and click rename and add your state, please, because we want to make sure we know who all is joining us and be able to answer these types of questions appropriately. Now I would like to introduce the team members of our hub. So today, Kristen, are you on that you can nope, Kristen's not here today. Okay, so let's go to Evelyn.
Good afternoon. Great to see everyone today. I'm Evelyn Nelson. I'm the PI for the Heartland Telehealth Resource Center and a psychologist here at KU Med Center.
Thank you, Evelyn. Let's have Rachel introduce herself.
Hi, everybody. Rachel Muter with the Missouri Telehealth Network, Show Me Echo, and the Heartland Telehealth Resource Center.
Thank you so much. Let's go to Tim.
Good afternoon, Tim Davis, Telehealth Manager for Oklahoma State University Center for Health Sciences in Tulsa, and the Oklahoma representative for HTRC.
That's great. Thank you, Tim. And Heather?
Good afternoon, everyone. My name is Heather Hagan. I'm a telehealth analyst at OSU CHS.
Thank you, Heather. And Robert?
I'm Robert Stiles. I'm with the Department of Pediatrics at KU School of Medicine and work with the Heartland Telehealth Resource Center as well.
Thank you so much. We are approaching the number where it's almost too much to be able to introduce everyone. Normally we do that when it's a smaller group, but today I'd certainly like for you to take that opportunity to introduce yourself in the chat. So in the chat box, if you would put your first and last name, your organization title, and state, we would greatly appreciate that. And that way we can save more time for the didactic. But we are so glad that everyone was able to join today. Have a few other announcements. Let me see if there's anybody on by phone. I don't see anybody by phone, so that's good. All right. Few more announcements. Well, it finally happened. During a Supreme Court argument today, it was proven that sometimes we all have difficulty finding the mute button. So during the argument of Barr versus American Association of Political Consultants, an unexpected sound projected clearly across the court's live audio stream. Yes, someone flushed the toilet. So this is just a reminder that to keep your button on mute until you're ready to speak. If you would like to ask a question, you may raise your hand and then we'll recognize you, and then we will allow you to unmute. Please introduce yourself before the question, and we'll avoid all of those crazy sounds that we might hear in the background. Isn't that funny? Oh my goodness, I couldn't believe it when I read that. We're just going to use first names today, so we can all just be equal, and no one knows more than the next person, okay? And be conscious of any kind of patient health information or confidential information. I don't think we'll have a problem with that during these telemedicine echoes, but you just never know. So let's keep in mind our confidentiality. Let's see, the didactic and any kind of case will be on box. We do not have a case study today, so that allows for a lot more time for questions. So Robert, you don't have to rush through your didactic. You can take a little more time since we don't have a case, but we do want to leave time for some good discussion and questions after your presentation. The value of the echo is in cases, so if you ever have a case study that you would like to present during this echo, please submit one, and we will answer those case study questions and have that discussion next time. So please consider doing that. It makes the echo just that much more valuable. So our didactic today is, he's no stranger to us because he's on the hub team, and you have seen him throughout this telemedicine echo. Robert Stiles has extensive experience in government at the state and local level, including serving as the director of Kansas Primary Care Office at one time. And he's also worked at the local level as an executive in the direct provision of healthcare services. He has done an excellent job keeping everyone updated in the tri-state area about the changes in regulations from CMS and from each state. That is no small task, and we're going to let Robert take it away.
Great, I want to thank everyone. Let me share my screen just a moment. And everything's always in the way when you're trying to find the slideshow button, but here we go.
No worries, Robert. I forgot to mention that if you have questions during Robert's presentation, please use the Ask Joe Kingsbury in the chat box feature, or just ask the question to everyone and we will try to get those questions answered if you're just too embarrassed to ask it out loud. Thanks, Robert. You can go ahead.
All right, well, thanks everyone. I appreciate the opportunity to talk today. I provided this presentation yesterday. I've tried to add a little bit of a highlight specifically on some of the things related to mental health. We talked both days about FQHCs, but also want to talk about some changes related to community mental health centers. So when I was asked to do this, I really wanted to spend some time on the CARES Act, which was the main stimulus package that was passed at the end of March. I wanted to say the end of last month, but we're in May now. I think time has taken on weird parameters and during the COVID-19 public health emergency. But just last week, CMS came out with a second round of pretty significant changes related to rules and regulation during the public health emergency, and many of those are related to public health, are related to telehealth. So I wanted to first briefly go over those today. On the HTRC website, there is a PowerPoint from yesterday at noon that is much more extensive, that goes over all of the CMS regulatory changes as well as regulatory changes in Kansas, Missouri, and Oklahoma. I would encourage those of you who may not have heard the presentation I gave a couple of weeks ago now on CMS and the states to download that presentation, which is much more extensive on regulatory changes at the federal level, as well as adding some information on the states in Missouri, Kansas, and Oklahoma. So I've been starting all of my presentations with this lately because one of the things that we're sort of moving into is, I wouldn't want to call it post-COVID, but maybe the normalization of COVID, meaning that, we've kind of dealt with some of the big changes and, states are starting to gradually reopen and look at how to move forward. And I would say when it comes to COVID-19 overall, as well as sort of telehealth in this new environment that we're in, what Seema Verma, the administrator for CMS, said last week in an interview with Becker's Hospital Review is really the thing we need to think about. She said the genie's out of the bottle on this. It's fair to say that the advent of telehealth has been completely accelerated, that it's pushed us to a new frontier, but there's absolutely no going back. And I keep describing it as really a rubber band. When you stretch a rubber band out, it does snap back, but it doesn't go all the way back. So some of the changes, that we're seeing related to telehealth and other things are, not going to be sustainable, right? They were a response to the public health emergency, but we're never really going to go back to where we were. CMS has clearly stated, the administrator for CMS has clearly stated that she doesn't see us going back either, that we've really accelerated something that was already happening. And so as we prepare for the future and for the current situation and the continuing situation that we're in, I think that's important to understand, because we're looking at telehealth as just a normal routine part of our life. And some of these things that have been very successful with the provision of telehealth services, I think we're going to see continue. And especially when we get through what CMS did last week and kind of what they've expressed their intentions as being, I think we'll see that they're committed as well, and as well as the state's Medicaid programs and even private insurers to some of the things that we're seeing. So last week on April 30th, CMS put out a new round of changes of guidance and policies related to COVID-19. And they had 5 goals for these updated policies and rules. And the third one is the one that we'll spend the most time on today, which was that they're updating their policies, they're changing rules, they're adding things, because they want to continue to increase access to telehealth for Medicare patients so they can get the care from their physicians and other clinicians while staying safely at home. So that's one of their 5 goals, right? We're seeing continued changes related to this because they think it's important. So when they talk about increased telehealth access, the changes that they made last week are really related of changing the types of healthcare professionals that are eligible to bill Medicare. They continue to expand the types of providers and the reimbursement as well, and expanding the types of services that are continuing to grow, the types of services that are eligible for reimbursement due to telehealth. So like they say, they've included physical therapists, occupational therapists, speech language pathologists for more services that they provide through telehealth. They're also adding, they started with kind of private providers, and then they moved into FQHCs and rural health clinics with some changes that happened in the middle of April. And now they're adding hospitals. So they're saying that they can now allow certain services that are remotely provided by hospital-based practitioners to patients registered as hospital outpatients, including those at home. So this is one of the big changes that we're seeing with these changes last week, is we're really looking at hospital outpatient services now being provided at home and being paid as if they were happening in the hospital. In addition, they added hospitals can qualify for the originating site fee for telehealth that's furnished by hospital-based practitioners to patients that are hospital outpatients. We're seeing that again there, that they're really trying to move telehealth now into this hospital outpatient area. So in addition, they're waiving the requirement for the use of video technology for interactive telecommunications for more services. So, when they came out with the changes on the end of March, that big round of changes, they came out with and said, hey, here are these telephone only codes that we're going to let you bill, and it can only be those. So what they're doing is they're expanding the number of codes that can now be telephone only, right, without a video component, to include some additional evaluation and management, E&M services, as well as allowing more of behavioral health counseling and education services to occur over the phone only, right? Because they're continuing to see that there are Medicare enrollees that don't have access or don't prefer to use a system that would have audio and video. So they're continuing to expand those services that could be telephone only, just audio only. FQHCs and RHCs are allowed to bill these codes. FQHCs, federally qualified health centers, and rural health clinics may bill for these codes, and they have special billing requirements as they really do for everything. FQHCs and RHCs are under a PPS. Why can't I think of the term PPS today? I know all these words, and I hate to use all these acronyms without telling you what they are, but they have a special payment system, which is called PPS. And so they have special codes related to PPS, G codes, that these are being billed under. So the other thing Medicare has done is, right, the first big change they made is they said, hey, Used to be you had to use place of service 2. There were specific codes. You didn't get paid as much when you were doing telehealth services as you did when doing those face-to-face. So that was the big change that they made first. So now they're saying, hey, we're going to try to, and what they did was they said, hey, bill it as if it happened in your office, bill it as if it happened face-to-face. And instead of using the O2 code and getting paid differently and basically not being paid as well, just add the 95 modifier, and you'll basically be paid the same as if it happened face-to-face. That was using telehealth, which would be audio and video, right? But now they're saying, hey, we're going to try to increase the amount for these telephone-only visits as well that don't include a video component to try to make those match the payments for similar office and outpatient services. So continuing to try to make it in everybody's best interest when possible and when it's appropriate to provide these services not only through telehealth with audio and video, but now to provide more of these services with telephone only when it's appropriate. And the final thing they said is, hey, it's taken us a while to make changes, right? And they go through, believe me, I've been in government before, regulatory processes take forever, and they're very complex. I used to have to go before the state of Kansas Rules and Regulations Subcommittee of the legislature, right? And appear before them and explain why I wanted to change the regulations and what the regulation changes would be. And there's a public hearing process and lots of other things. And it's even more complicated when it comes to the federal level. So what they're saying now is, hey, we're going to do sort of a sub-regulatory process to review services that can be furnished through telehealth and add them to the CMS eligible telehealth list. And they've said that they're going to listen to local providers who are telling them new codes that need to be added. And they're not going to have to go through quite a complex process anymore and be able to add those more quickly. And so they'll just continue to update that list as they add codes that they think are appropriate, and really an expedited process to do that because they want to be able to offer, update those codes and add more services that they think are appropriate for telehealth or even through telephone in a much quicker manner. So I wanted to hit something that I didn't hit yesterday morning because this one's focused on behavioral health as well, which I know lots of behavioral health is not provided in community mental health centers, but they're sort of bringing them into the party. They're saying, hey, we're going to let community mental health centers do some things through telehealth that they weren't allowed to before because we want to really increase their ability to provide these services in a way that's safe and secure for patients that might be exposed or at risk of COVID-19. So in these changes, they're out allowing community mental health centers to provide partial hospitalization services along with other services to the individual's home and bill for that and get paid for that. They indicate that there's going to be some regulatory changes, and it's really interesting in the document. You know, these things get rushed. So they basically say to be released, you know, put the notation in here that tells you what the regulations are, but they don't apparently have those regulatory changes made yet. And I did a search for that, and they're not available. So, but apparently there will be some regulatory changes as well that are going to be released that will clarify how community mental health centers would bill for home-based services and what documentation is required. And this is really similar to what happened with federally qualified health centers and rural health clinics. You know, the CARES Act was passed at the end of the end of March. And what happened was it's actually April 14th, 2 weeks, which is very fast for CMS, very fast for any government entity. They came out with an MLN special edition that finally told the FQHCs and the rural health clinics what to do, how to do it. So they were able to do distant, be the originating site and some other things, but it took a couple weeks for them to put those regulations out or the rules out for how to do that. So I would be, if I were a community mental health center, I'd be looking for those regulations, and I don't know how those will be released, but it sounds like they'll be released soon. So you can do it now, but we're not really sure how you should bill for it and how to document for it. So that'll be coming out soon. It does include the provision of providing these services through telehealth to the home. And then the other thing they're doing is they're going to waive the 40% rule, which required that 40% of patients not be Medicare receiving services. And so they say 60% or Medicare enrollees, that's fine. We want to make sure that those services happen. So some other, which actually I added that slide before today and didn't update this slide, but there is those that work with Medicare, the shared savings, the ACOs, the accountable care organizations. They've made some changes to that as well. They feel like under COVID-19, that process is, basically you take on more risk and you can make money off of that. You can get paid money by reducing costs to Medicare, or as you go through the ACO process, you can begin to take on risk, so that if costs go up for Medicare, then you basically owe Medicare money. So what they're saying is those that were about to go up another level in the risk level for the next year as they go through that ACO process, that they're going to freeze that. And so those ACOs will have the option of not moving up to another level of risk where they take on more risk with Medicare next year, because they believe that COVID-19 is going to obviously increase costs in ways that they're not really understanding yet. So the thing to know, CMS has provider-specific fact sheets related to all kinds of different types of providers: hospitals, teaching hospitals, healthcare providers, home health, hospice, and those have all been updated as of April 30th of 2020. And wanted to bring that up because it's pretty important. Many people have been using those provider fact sheets about the regulatory changes specific to the type of entity that they are. And if you're using the one before April 30th, you should really go online and download the newest version that was produced, because all of those, like I said, have been updated as of April 30th to reflect these new changes. The other thing I wanted to make sure everybody knows is we do have policy documents on our website, the Heartland Telehealth Resource Center website, under the COVID-19 section. So we have a federal policy document that goes through all of the federal regulatory changes, as well as not just CMS, but HIPAA changes and Office of Civil Rights and Office of Inspector General and Stark Law and some other things that have been changed, and some modifications that they're doing related to COVID-19 to help facilitate the provision of healthcare services. So those are available on our website as well. We have policy documents related to Missouri, Kansas, and Oklahoma, specifically really focusing on state level changes, governor's executive orders. We highlight when the states of emergency are ended in each state. Off the top of my head, I can tell you that Missouri is the end of May, Kansas is the end of May currently, and Oklahoma is at the latest there right now, June 15th. So anyway, please go out and get those documents, and they go into all of this in a lot more detail than I'm able to go through today. So this actually was yesterday, but we do have the PowerPoint, like I said, available on our website from yesterday that goes through all of this federal and state policy as well, including a more detailed description of the CARES Act, which we're going to go to in a minute here. So talking about the CARES Act, right, there was one really initial period of stimulus and policy changes that was made by Congress and then signed into law by President Trump. That happened on March 6th. And a lot of what we saw early on with regulatory changes, like allowing telephone with audio and video, which wasn't allowed before, who qualified as a provider for telehealth, emergency areas, emergency periods, and declared the emergency, all of this is related to the emergency declared by President Trump that goes back to January 31st of 2020. So on March 27th, Congress passed and was signed into law by the President, the CARES Act, the Coronavirus Aid, Relief, and Economic Security Act. And the thing to know about this stimulus bill is it's very similar to the 2008 stimulus bill. It has some things that are really specific to COVID-19 and to our response to that, as well as really trying to get the economy going and putting some funds into a lot of areas that really matter with the provision of healthcare services, things like workforce programs, some of the federal programs like the Office for Health Policy, and many of their programs, as well as a lot of other things. So the thing to pay attention to, there's a lot to pay attention to, but the area of the CARES Act that really applies most to what we would be talking about in the healthcare environment and telehealth services in particular is Title III. And then you can see on this slide, so that's why it's red there. And then when you look at Title III, those items here that are in red, Part 2, Part 4, those have the most areas that really would impact not only the provision of telehealth services, but really local providers and the types of opportunities that may be available for increasing access, increasing workforce, and those types of things are in these sections related in red. So not to go through really in detail, but I wanted to include, and these PowerPoint slides will be available after today's presentation in the box for the ECHO series. So you can go down online, go to the box that's related to this ECHO and download this PowerPoint. So you can see, for example, that there's supplemental awards to FQHCs, to health centers, 1.32 billion. But the thing that I really want to point out, and 3212, the next one on this slide, kind of points that out. This is Telehealth Network and Telehealth Resource Centers grants, right? So HCRC receives one of those grants to cover the states and provide assistance in Kansas, Oklahoma, and Missouri. But what you see in a lot of these is that they're putting funds in for federal fiscal years 2021 through 2025. So this is not just a stimulus, and it's not just money right now related to COVID. It's really increasing funds and continuing programs, many federal programs through federal fiscal year 2025, and actually putting money for all those fiscal years into those programs for now. You can see Rural Healthcare Services Outreach, which I would encourage anybody in a rural area to take advantage of the Office of Rural Health Policy grant programs, Rural Health Network Development, Small Healthcare Provider, and then the Rural Healthcare Services Outreach. That too got funding through 2025. So you can see there's a lot of other things, flexibility for some things related to the COVID-19 emergency, like allowing National Service Corps members to kind of go and provide services if their hospital or where they're providing their care isn't accessible. So lots of things there, things related to substance use disorder, protected health information, health professional workforce program that's being reauthorized through 2025, nursing workforce development, which is often not been one people think about the National Health Service Corps program a lot. They think about the state loan repayment program a lot, but the nursing workforce program, especially the nurse loan repayment program, is a really good opportunity that often hasn't been funded as well as National Health Service Corps and some of these other programs, but nice to see that that's going to have continued funding, and hopefully nurse managed health clinics, which I don't think are as very common in Missouri, Oklahoma, or Kansas, but an area that there has been federal funding for as well. So exemption of telehealth services for safe harbor, for deductibles, flexibilities, telehealth services for FQHCs and rural health clinics. This is what allowed the distance side and some of the other things that we're seeing roll out for federally qualified health centers and rural health clinics during the emergency. So some, you can kind of see a wide variety of things. I would encourage any of these that matter to you as a local provider, to your entity, certainly to find this section of the CARES Act. If you have questions about it, we can certainly provide any information we can find, with all of these things. But one of the big ones, which they keep doing, 3813, those small hospitals, right? We thought when we did the ACA and everybody would have Medicaid or be eligible for Medicaid, that to higher levels of poverty, that one of the ways they paid for that was decreasing disproportionate share hospital payments. And we keep putting that off into the future because we're seeing states like Kansas, Missouri, and Oklahoma that didn't expand Medicaid, and that the hospitals would take a real hit if those payments went away. So those are now at the end of fiscal year 2022. The other thing on the behavioral health side, when you talk about community mental health centers, the expansion of the community mental health services demonstration programs, which Missouri was one of the first states to get that, to kind of create a different payment model more similar to what federally qualified health centers receive for community mental health centers. And so it does look like that's been extended. They will be adding 2 additional states and 2-year demonstration projects for those states that are not currently involved in that demonstration program. And those that currently have planning grants for that will get priority for that funding. So talking about opportunities right now, I want to make sure that everybody's very aware of the FCC program that has $200 million in funding. It helps healthcare providers. The real priority for this is providers that are providing services to medically underserved populations, to those access issues or low income or uninsured, as well as those areas of the country that are most affected by COVID-19. So the money will last until the money runs out, until it's been expended. They've awarded the $200 million or the pandemic has ended. And one thing to know is these funds are limited to nonprofit and publicly eligible healthcare providers that fall within the federal category of healthcare providers. So you'd want to go to the FCC website and make sure that you qualify both as a nonprofit and public eligible healthcare provider for that program. So here's the steps to apply for funding. They began accepting applications on April 13th. There's a limit of $1 million per individual applicant. What I've seen so far, and we'll see in a minute, most of those applications are not for $1 million. A couple are. Have a couple of organizations, including I believe the Mayo Clinic, has received $1 million from this, but many of them are more like 300 to 700,000. It seems to be. And you can see there that the application materials are available, and you do have to do an online portal and do your application at that FCC website that's listed here. So the types of services, here's the list of kind of what you would apply that you're doing with the money, able to provide by getting the money. And then the conditions, right? So it's COVID-19 patients directly, those with other infectious diseases, emergency, kind of helping increase capacity in the whole system, not only just for those COVID-19 patients, how that frees up resources to treat COVID-19 patients. And then the services that you can provide, that you can get money to help provide, telecommunication services and broadband connectivity, which is through the USAC funding. Many people have already been receiving assistance with that. Information services, so remote patient monitoring platforms, store and forward, things like that. And then internet connected devices and equipment, including things like tablets and smartphones and those wonderful devices like broadband enabled blood pressure monitors and pulse ox. And I would remind everyone of the presentation we had last week from TTAC about they can really provide assistance as you look at different types of technologies and what's going to work well in the area of telehealth, especially when you're looking at those things like pulse ox and blood pressure monitors and some of that, as well as just cameras and other equipment that you want to really have good, strong, you want to make good purchases with these funds because hopefully you'll be using them for a long time to come to provide telehealth services to your patients. Like I said, the criteria takes into account really those conditions that you're treating. So really the idea that you're working with a population that's underserved, understrained, and those that are really impacted by COVID-19. So they made 4 rounds of funding to date, totaling $13.7 million. And you can see there's a long list of those who've received these funds. There have been no entities in Missouri, Oklahoma, or Kansas that have received funds to date. I know there are entities that are in process or have already submitted their applications. And you can kind of see, I really wanted to point out the 4 rounds of funding because if you go to the FCC website for this program, they have press releases that detail all 4 rounds of funding that have been released so far. And this is just a list of who's received them and where they're located. But the other thing, each of these, they then list sort of a brief synopsis of what they're using the funds for. And so anybody that's applying for this funding or interested in this funding, I would really encourage you to go look at what the FCC's already funded, what people are using the money for, because certainly that's eligible, that the FCC seems to find favor in those types of things because they've awarded funding to those things. So I would really encourage anybody to read those press releases and see what people that have already been approved are using the funding for. So we do also want to point out the normal USDA Distance Learning Telemedicine Grant Program, which is an ongoing program, not a new program like this FCC program. It had already closed for the year, but because of some funding out of the CARES Act, there is a second application window open. It opened on April 14th. It lasts through July 13th of 2020. And those materials, you can see the website where you can link and get the guidance to do that application. And like I said, you can apply for that through July 13th of 2020. So I did want to talk a little bit and very briefly about Section 3704 of the CARES Act, which directs CMS to develop telehealth payments for rural health clinics and FQHCs during the pandemic. So on April 17th, just a couple weeks after it passed, 2.5 weeks, they put out an MLN Matters special edition article on telehealth, which goes through allowing FQHCs and rural health clinics to service distance sites during the emergency. Any healthcare practitioner working for the RHC or FQHC can provide those services if it's within the scope of their practice. The practitioner can furnish those telehealth services from any location, including their home, during the period, the time period, and acting as an employee of the RHC or FQHC. So there's kind of 2 periods of billing because Medicare said we don't have time to get our payment systems updated. So on January 27th through June 30th of 2020, you're going to bill those codes with modifier 95, use the revenue code that would have been blah, blah, blah. And the thing to know is Medicare is going to make it right. So you're not going to get paid the way you necessarily would have been. When the new payment rate's updated in July, then they'll be doing payment adjustments to kind of make up the difference if you end up getting paid less than you should have been under the new rules. After July 1st until the end of the public health emergency, then it's a little simpler. You use code G2025. You're going to be paid $92. And that's because in the CARES Act, it was very specific that this couldn't be a PPS, a prospective payment system. Finally thought of what that stands for. Payment, that it had to be based basically on sort of the going rate, fee-for-service type rate. So what they did is they averaged the amount of the services on the telehealth list. They weighted it by what the volume was for they thought those services would be, and they came up with $92. So that's what you'll be paid. So then here's information. Everybody that has a cost report probably contracts with someone or works with someone closely, and certainly they're going to be aware of how to do this, but this is where the feds have directed for those telehealth costs to be reported. So did want to also really briefly mention communication technology-based services, which have not been open for RHCs and FQHCs. So this is the virtual visits. The one thing that's not still allowed is remote patient monitoring, but those other two types of communication technology services, which aren't considered telehealth services, there's sort of visits through or conversations or care for a patient that's done either through the patient portal or through telephone or some other means. So those are now allowable, those two types of services for rural health clinics and FQHCs. So that's really the presentation today. I wanted to remind you of the National Consortium of Telehealth Resource Centers has a telehealth webinar the third Thursday of each month, the next one that's coming up. I know Janine will provide more information on that at the end of this. If you very much, the Heartland Health Resource Center is here to serve you, and certainly please reach out to us. And we're happy to answer your questions and provide you any input that we can to help you out as you look at providing telehealth services. If you have any additional questions regarding telemedicine, contact the HCRC. If you want to learn more about the Show Me Echoes, please visit the showmeecho.org site. And I will quit sharing now and let someone else talk, hopefully.
Thank you, Robert. That was a very thorough presentation. And now we're going to open it up for any kind of questions that you might have for Robert or for the rest of the group. So Joe, do we have any questions?
Nothing yet.
Okay, so now we're going to give you a little time to come up with any of those questions, or if you want to be brave and just ask it through video or phone, just go ahead and ask.
Robert, this is Evelyn. Last time I heard you present, you had shared that the funding was available for school counseling and just some avenues that I hadn't thought of. Can you give a couple of those kind of off the beaten path examples?
Well, sure. The questions that came up yesterday there was both Truman State in Missouri, which is a state institution, which would be a public entity, as well as William Woods College, which is a nonprofit public university, a nonprofit private university, excuse me. And so those were really the healthcare systems, the university healthcare systems, and they were talking about some services and whether they would qualify. And so they would certainly meet the nonprofit and the public entity requirement, and you'd want to go online and go through the FCC website and make sure that you meet the definition of healthcare provider as well. So there are, certainly some great opportunities. The other one I can think of is Missouri, I know, has really expanded the ability to provide behavioral health services in schools. I was involved in that when I was in Missouri before this, and was really excited when Medicare changed the rules to allow place of service code 03 to be used. So certainly school-based services, as we look at what's going to happen next fall, and as we even look at how we're providing healthcare services and behavioral health services to schools for kids that are at home, that's something that we work with, Dr. Nelson and I work with quite a bit through the Kansas Telehealth Rocks program, where we're providing behavioral health services to schools and now providing those to homes, and schools are not, in session, or they're in session, but they're doing services at home. So I think there's a lot of opportunities to really look at ways to provide healthcare. And this is what I think is really interesting, and what, when we talk about that telehealth is here to stay, and we accelerated it, but we're where we were going to be. I think there's a lot of opportunities, and I think there's a lot of really interesting services that, like I said, I would really encourage you to go read the 4 press releases for what they've already paid for, what they're already, FCC is giving people money to do, because I think that's really going to help people come up with ideas for some innovative things that they might be able to do as they apply for these funding. I always say, it's easy to get money. The hard money is to get money that pays for a salary ongoing, right? And the other one is technology, buildings, capital equipment. So this is a great opportunity for capital equipment to maybe allow you to begin to move in some of those things that you've been wanting to do or that you see a real need for, as well as when we talk about the provision of medical services, vitals is key, right? And we're not collecting vitals, and we're going to have to figure that out, right? We're not going to be able to continue to provide medical, telehealth, telemedicine, and not collect vitals. So that's another really big opportunity area to look at how can we make this work better, so that we can continue to provide some of these services to people that may be homebound, that may be at risk, that really shouldn't be leaving the home anyway. But we've got to come up with a complete approach, whatever that is, whether it's behavioral health services or medical services or dental services as well, which next week we're going to talk about teledentistry some, that allows us to provide the highest level of care in the most appropriate manner. And what's exciting about all this, I think we're finding some places where telehealth is better and always makes more sense. You can see what's happening in the home. You can look at a child's development. Right? And a couple of weeks ago, that came up, and we had a physician saying that he likes doing Medicare wellness visits through telehealth because he can see the home, he can see trip hazards, he can see fall hazards, he can see people in their natural environment. So there's a lot of opportunities here. There are times where we're going to want to go back to the way we did things before, but I think there's a lot of opportunities to do things in a different way. And to be honest, there's a lot of funding available to do those things in a different way.
All right, Joe, do we have any questions that have come in yet?
We do have a couple, and since the crew is relatively manageable in size today, Suzanne Opperman, I'd like to give you an opportunity just to unmute and ask your question directly of the hub team.
Okay, that would be fine. I have a small private practice, so everything I see so far from yesterday and today is all for the FQHCs and the government-based clinics. Other than the SBA loans that are being re-offered again, is there anything along the lines of smaller entities? I do all teletherapy, and the town our size, there's a lot of us trying to figure out how to juggle all this, especially since we have really crappy internet.
And that is one of the unfortunate parts of all this. Whether, I was an entity, a local rural local nonprofit that, you could always been able to get the USAC funding where you get reimbursement for the partial cost of your broadband as much as 60%. I do think that you're absolutely right that private for-profit providers who are often in many communities, especially when you talk about behavioral health, the backbone of, the sort of routine services are not, these programs are not accessible to them. And that is unfortunate. The positive, or the one thing that I can say, right, is you're billing Medicare and Medicaid, hopefully. And those rules are the same for you as for anyone else. But in terms of the funding pots that are available, the increased funding, the funding for health centers or for broadband or for telehealth equipment, unfortunately, that's not accessible to private providers.
That was my basic question, because I don't charge anything right now. I'm just offering services for free because there's so many people in the smaller towns. There's no work. I mean, even the hospitals, nurses are laid off here.
The only thing, is if you were contracting with an entity that did qualify, then they could provide, like, say, example, broadband connectivity to patients or tablets, through a contact with someone who did qualify. But it's always a problem, especially when you talk about the mental health care system. That's a much more private system often than, you have community mental health centers, you have FQHCs, but in the rest of the world, you often have, and when you're talking about primary care practices, you do have a number of those that are owned by, right, nonprofit hospitals that can qualify for these types of things. But you don't see that in behavioral health.
So my past experience has been with community coalitions, and at times I've been involved with community health coalitions who got together as a 501c3 so that they can apply for some of these types of grants. And then as a community, they would work with providers to, supply them with the operation needs that they were, absolutely needing. So there might be the opportunity for a local coalition to apply for some of these and work together as a consortium to maybe bring some of these funds into a rural town. All right, Joe, any other questions?
There was one posed by our hub member, Rachel, asking, is anyone on the call not using telemedicine for patients yet?
And my follow-up would be, if everybody's using telemedicine, that's great. I would want to know, especially if you're new to doing this, what do your patients think of it?
Suzanne, if you're talking to us, you're muted.
Of course. I do that. I do all this by group too. All the groups that I do locally, I've migrated those to Zoom. I'm under the umbrella of an international volunteer organization, and I'd say only about a third of my clients are getting on the Zoom groups with us. The rest, when I've contacted them individually, they just want the one-on-one contact. They're not comfortable with the telemedicine platform. I try to encourage them to give it a try, because really, especially with the video, most of them don't feel it's that much different and are finding it very valuable.
That's a great comment, because, you know, the unknown is a lot of times what holds us back, that fear. And a lot of times I've heard that patients, once they get used to it, are more apt to come back and try again, and then they don't want to leave that kind of mode of therapy. So that's interesting. And then Melissa Martin says they prefer audio over video. So that's understandable as well. And I think we've had some discussion about that. I think Kristen actually addressed some of that with families. You know, I want to see your smiling face. I want to see you, or, you know, that type of thing, and connect that way. So there are ways that providers have been able to convince people to turn that camera on. And then Karen, you want to provide us your tidbit of information that you put in the chat? I think that's very interesting.
Oh, I just saw on the dailies today that the AMA came out and publicly sort of called on the federal government to keep the relaxed rules around telemedicine even after the pandemic, which I thought was interesting. One of the key pieces of that, though, that concerns me a little bit is the loosening of the rules around licensure and cross-state care. And while there's a lot of that goes on, and there's a lot of high quality care, I still worry a lot about the direct-to-consumer environment where there's anonymous, you know, disconnected, asynchronous care, where, you know, we've done studies in my field on this, and some really bad stuff happens when you don't know somebody's problem list, their allergies or their medications, or you don't know the infrastructure or culture that the patient, in which the patient exists, and what their resources are. I always say, when I lecture, I say, if the answer to what happens if something goes wrong is to go to your local emergency department, that is not high quality care. So that worries me a little bit, that licensure piece, because there are always going to be bad actors out there trying to make a buck. I hate to say it. And I think we need to, in the telemedicine world, we need to do everything we can to make sure that the same standard of care applies, no matter what kind of technology we're using, and that we focus on patient safety and high quality care.
Very good. Rachel, you have a comment?
I got a private message to have me explain a little bit about the free Zoom licenses that are offered here in Missouri from the Missouri Telehealth Network in partnership with MoreNet. And we've got lots of these left. The free Zoom licenses are available mostly to non-for-profit healthcare organizations. You would just go to showmeecho.org and register. And if you don't fall under one of the categories listed there, then I will get a separate message to give the opportunity to have me approve that license request if you're not one of the listed organizational types. Those licenses are only good until the end of June. I'm currently in talks with Mornet to see if we can figure out a way to extend that, but I don't have any new information on that. The licenses are covered under the University of Missouri BAA with Zoom. So they are the encrypted type of Zoom license, and they are not, there's no recordings on these licenses. The way that we have set them up is that there's no recording available.
Very good. Thank you for that. That's great information. That's a great resource for those of you that may need that type of thing. And when we're talking about Zoom and the encryption and the way that you can tell the difference, if you'll look up to the top left of your screen, it will say whether it's recording or not. And then there's a little green lock, and that means that this Zoom is secured and encrypted. So that's how you can tell the difference between the Zoom that's not and then the Zoom that is. So, and it's nice to have that. And I know that right now they've relaxed those standards, and that's something that is also a little bit concerning, that you know, you might as well start best practice now, even during COVID-19, and use that secure and encrypted platform. So that's a great service, Rachel. Kansas and Oklahoma would do well to offer the same. Any other questions, Joe?
No other questions. I just wanted to add one quick comment on your green lock up in the left-hand corner. For those of you running Zoom version 5.0, which is now out and available, they changed the little green lock to a little shield with a check mark in it. So if you're looking at your top corner and you're like, oh my gosh, I don't see the green lock that Janine's talking about, it's now the shield. So so either the lock or the shield, you're set to go with encryption.
I'm not updated. Very good information.
I just wanted to announce that I think you all know that we also have a COVID-19 echo every week, Mondays from noon to 1, that you're all welcome to. And I just today asked Dr. Randall Williams from Missouri, who's the Department of Health and Senior Services Director, to spend the few minutes at the beginning of that hour just giving the update for our state. So for those of you from Missouri, if you come on at noon, you can get the little update from Dr. Williams about what's going on in our state.
Ah, that's excellent. Thanks for that reminder. Wonderful. All right. Well, we're going to abide by Karen's suggestion that Zoom fatigue is something that is certainly evident, and we're going to let you go a little bit early so that you can get ready for your next appointment at the top of the hour. So thank you for joining us. Join us again next week, and we're going to talk about teledentistry. Thank you.